Okay, so we're going to move on to end-stage disease, end-stage kidney disease, dialysis and transplant. And so when do you have to worry about end-stage kidney disease? Well, that's not treated until you get to CKD stage 5, which means you have less than 15% function. And should you treat with dialysis and or transplant? Well, that's something you have to start planning for ahead of time. And for low syndrome patients, I think you should be starting to talk about that when they're at CKD 3 or 4, where they have 20 to 50% function, because you want plenty of time to think about those decisions and to consider the options when your son is well. So what questions should you ask? And I think the number one question is the current quality of life good? And will the quality of life be worse with treatment of end-stage kidney disease? For example, can the patient sit quietly for 4 hours or more in a chair for hemodialysis treatments 3 times a week? Will the patient leave an indwelling peritoneal dialysis catheter alone or try to pull it out? Does the patient have problems with frequent blood draws or injections? Does the patient take medications well and on time? If not, that can be a real problem. Has the patient had surgery before without problems? Are there other difficult medical and or behavioral issues that should be taken into account, like seizures, severe scoliosis, heart disease, behavior that really cannot accommodate these kind of therapies? And Mike Alberts is up here because he's recently gone through the transplant process with his son 2 years ago, right?
It's actually, October will be 5.
5 years. So Mike has a lot of answers to your questions. So a couple of things to set the stage for a transplant. Transplant is adding a kidney, and the kidney is usually placed in the body separate from the place that the native kidneys are. So we don't usually take out the native kidneys, okay? And the transplant is shown here in the pelvis, and it's close to the bladder, and it's the native kidneys are still in place. So there are several types of transplant. There's a deceased donor transplant or a living donor transplant. For a deceased donor transplant, you have to go on the wait list, and for an adult, that may be a 3 to 10 year wait time to get a transplant. For a living donor, you may not have anyone who has the right blood type or tissue type match for a living donor, so nobody may be able to give as a living donor. The most desirable thing would be to have a preemptive transplant, which is done prior to the need for dialysis. And you can be listed as active on the transplant list when you're not yet on dialysis if the estimated GFR is less than 20 mLs per 1.73 meters squared. Now, transplant is not without problems. So there's the risk of rejection, and that means you need timed oral anti-rejection medicines 2 or 3 times a day for the rest of your life. You're going to have frequent blood draws. In the first 3 months, it's especially frequent, often daily, then weekly, then monthly, and then much less often after the first 3 months. And then there's an increased risk of infection in the urine, or bacterial infections or viral infections, because the anti-rejection medicines suppress your immune system's ability to fight infection. And the final thing you have to know is that one of the things we worry about with some diseases is whether they will recur in the transplanted organ. And it's likely not going to happen. There's not much experience, but this is a genetic problem of the cells in the native kidney. And that doesn't happen in the transplanted kidney. So those cells are normal, so you shouldn't have recurrence of the kidney Fanconi syndrome in the transplanted kidney. So I'm now going to involve Mike here. He's got a lot of good information. And one of the things that we talked about before, Mike, was that you started planning early. So you want to tell us about your experience of planning and how you decided to go for transplant?
Yeah, thanks, Dr. Brewer. First off, we are real blessed to have somebody of Dr. Brewer's caliber and interest in helping us. I mean, her knowledge is just so helpful. And actually, we referred back to a lot of stuff while we were going through the planning stage for our son, Kyle. Kyle's 36, and he was stage 3, and based on the chart, probably 3B, and was pretty stable there for a fairly long period of time. We had to make the transition, as most of you have, and will, from going from pediatric nephrology to adult nephrologists. And it's two different specialties. And so you've got to be aware that they become familiar with that. We've been very, very fortunate that we had good resources in our town of Wilmington, North Carolina, and we had an excellent adult nephrologist who suggested it for us. My wife and I made the decision that dialysis would not be an appropriate option for Kyle, and our physician had agreed, partially because of Kyle's behavior, not tolerating, not even understanding why and how he could be sitting in a room for 3 hours, 3 times a week. And,
4 hours now.
Yeah. And
we now do 4 hours because we know 3 hours is not enough.
And that was just knowing your son was a big part of it. The other option that Dr. Brewer mentioned that we examined and actually went to class was peritoneal. And we actually had the surgery for Kyle to implant that in advance. That's when you do dialysis at home at night, okay? And that required an operation. They do an implant, but they did not have the, what do you call the catheter out because he hadn't needed it at that point. We were just doing it as planning. And as we've gone through the classes that are required and are very helpful, and also our experience with another child that has Lowe syndrome that did go through peritoneal, it has a lot of complications associated with it. We actually sold our house and downsized to get Kyle on the ground floor in anticipation of that and in anticipation of having all the medical supplies that you need that are going to be required for that. And
Mike means medical supplies for home peritoneal dialysis, which often takes a small room for storage of the peritoneal dialysis fluid and the other supplies you need for that therapy.
And after even having the surgery, we realized that that was probably going to be our least favorite option, just because of risk of infection, and we know Kyle messing with all the things that Dr. Brewer had a great chart up there earlier. If they mess with that kind of stuff and get it dirty, you're looking at infections and issues. So,
So Mike, I put up a slide on what things about dialysis, like sitting in the chair, and for peritoneal dialysis for them to look at as well. So you can see what Mike is talking about here. There are 2 kinds of peritoneal dialysis, one on the cycler, one on bags. The one on the cycler is done overnight, but you have to be sure and connected to a machine, has less chance of infection, but it's easy for the child or the adult to mess with the catheter, pull it out, do different kinds of things. I've had kids bite the catheters, and that introduces infection. Yeah, you can also do what's called ambulatory peritoneal dialysis, which are bag changes 4 times a day. That's more chance of introducing infection, but what can happen is you can empty a bag, put it in a new bag, disconnect, and roll up the empty bag, cover it with a bandage, and that might keep the patient from messing with the catheter, okay? So dialysis is not easy.
No.
And it may not be appropriate at all for many of the patients with Lowe syndrome. And it is okay to make decisions about your child that not to do this kind of therapy, because what you don't want to do is prolong suffering as opposed to prolong life. And so
I totally agree with that. And it's a very personal and hard decision. We actually had a family meeting. And again, Kyle was on the transplant list. And that was always our best hope. But after knowing him and these other options, we made the decision that we weren't going to do the peritoneal. We couldn't do the dialysis on site. So we were doing end of life planning. And Kyle became lethargic. And all of a sudden, 10:30 one night, 3.5 years after being on the transplant list, we get a call. And they said, 5 a.m., you need to be here. Now, we were 2.5 hours away from the transplant center. And we said, we're 2.5 hours away. And they said, well, you got about 15 minutes to get your stuff ready. And they tell you, keep your bag packed. Well, after 3.5 years, I'm sorry, I don't even know where my bag is. So we got in the car, and we also made a mistake. We took 2 cars. My wife took one, and I took one, because we didn't really know what to expect. Because you go through the process during transplantation. You talk to social workers. You talk to the surgeon. You talk to the head of transplant nephrology. And they really, they tell you. And they want to judge, do you have what it takes as a parent? Does the child, and I'm sorry, they're all kids. He's 36, but he's a kid. Is he going to be, does he have the supports necessary to go through this? And it's a very honest and open thought. And then Dr. Brewer said it's a quality of life issue. Well, one of Kyle's blessings is every single one of these boys they are joyful. And he's always been happy until he's not. And then we wanted some of that back. And as a parent, you want to do everything that you possibly can. I don't know about your boys, but Kyle was fairly difficult. We had a behavior therapist that helped us come up with protocol for Kyle to help with doctors. And that includes dentists, blood draws, things like that. And we actually presented it, and we tried to make sure we had the same phlebotomists that were familiar with Kyle, that he was familiar with. And that can be difficult, but we presented that to them. And he never liked it, but he became a pro. And he gets blood work every month still. And this is a kid who, he won't wear a Band-Aid. No, he won't wear, and so here you're having kidney transplant, and you're in the hospital, and they also had to take out the peritoneal stuff, and that was very difficult, actually. We had problems, we had an infection, we had drainage problems, and things like that after the surgery. But again, it's been almost 5 years, and now we look at different lab testing. We also don't have to take any sodium bicarbonate. Now we take a anti-rejection medication.
It's a different set of medicines, but it's still lifelong medicine. So
the other thing.
So I have a patient who's so needle phobic that even with therapy and with the same phlebotomist, and he also can't sit still for longer than 10 minutes. So
Yeah.
he just would not be a good candidate for this kind of therapy. And you can't put a square peg in a round hole. And you have to think through this, and you have to decide. And there's no judgment in not continuing with a therapy that's life-saving, but not necessarily life-sparing in terms of the quality of their life. So your boy may be a great candidate for this. I have some of my patients who would be really good candidates for this. Yeah, but I have others that are just not good candidates, okay? And so you just have to...
It depends on the individual and the supports that are available. And obviously, if parents of boys with low syndrome, I mean, just being here, there's the supports. But everybody, and I will also say it was somewhat challenging for us because Kyle got his transplant in October of 2020 when we happened to have a little bit of a problem called COVID. And when you're on anti-rejection medication, you know, and you're susceptible to things, you've just had a kidney transplant, it was actually ended up outside of the hospitalization where they try and keep you out of the hospital, multiple people out of the hospital. As you know, most chances you got to stay with your son, you know, because our sons require that, or at least Kyle does. He's not going to be alone in the hospital. And they understood that. But you have to be an advocate for your son, as you always have been. And we didn't have a problem after they saw that we were effective advocates. But that is another hurdle. But the good thing is COVID had automatic isolation. And so we didn't subject Kyle to any diseases or anything because we were stuck in our house or on our porch and things like that. Bad news is he's so social that it really kind of affected his life because he only got to see his parents and sisters, which he got really tired of.
But sorry to interrupt. I know we're running a bit behind, so we're going to have to maybe wrap up with any last comments, or maybe we just go ahead and wrap now. And
So,
Dr. Brewer and Mr. Alberts will be here all through the rest of the conference and tonight. So I encourage you, if you have questions for them too, to make sure you talk to them. But any last comments from?
No, I just put up the slide that says "Ask us later,"
Yeah.
Because we're here all day. And we know you have questions about this, and I'm happy to answer them. Mike is great because he's had the experience, and there's not a whole lot out there. And I was really impressed with how Mike and his family dealt with this and were able to get through the process. And
thank you.
And I'm also glad he got some really good physicians and surgeons in Carolina to help him.
Yeah, no, I appreciate it. We're just so fortunate. And thing I want to leave with you is there's always hope. And it's what keeps us going. And just remember the joy that they give us and they give everybody else. Thank you.
Thanks, everyone.
So much.